So, welcome to NUR203 Exam 2 review. Let's go over these big, broad concepts and try to bring them down to an understandable way. Now, the first exam had all those theorists, and those are rough. Now, you always will see questions regarding adolescents and involving them in the care because that's part of their discovery for their roles in the future. Okay, they've got to start getting more involved in the care. So those are type of theorist type questions you might see, but nothing more than that. So we know exam two, if you're on campus, let us know. Some do, some don't. But anyway, here we go. This is week 4, 5, and 6. And let's do the eye things. Now there are 3 eyes conditions we talk about. One is amblyopia. Amblyopia is a lazy eye. What it means is one of the muscles. It turns up, down, in, out, could be anywhere. But the muscle pulls it, or this muscle's not strong enough to pull it back. So, how do you strengthen a muscle? You make it work. Cover the good eye, let the bad eye work, and it's going to strengthen the muscle, and rarely, no more than that is needed. Now, strabismus and the other one is nystagmus. They're similar but different. Strabismus, their eyes, where if you put your finger out, both eyes will get onto that finger. With strabismus, you can't focus. So your eyes pass midpoint, is what they say, because you should be going to here, but now this eye's going more, and the other eye's going, so it's crossing them. So it's cross-eyed. Okay. Now, the other one, nystagmus, is just twitching of the eyes. I didn't put it down there on the slide. Now, like cognitive impairment, what are you going to see? Well, if the infant looks different, the Downs child, and there's other conditions too that have these certain sort of dysmorphic looks, you'll be able to tell. Now, as they get older, if we haven't immediately figured out what's going on, you're going to see certain things with these children. Now, last exam, you had to learn all of these growth and developments of these infant first year of life. And it's like so much. And why do you need to know those things? Well, let's say your child is, or a child that you're assessing as early cognitive impairment. You as a nurse, what would you see? Well, there's going to be fine and motor delays, as in by 1 year, they may not be doing blocks of 2. They may not even be grasping or even do a fine pincer grasp. That's the fine motor fingers, right? F fingers. The gross motor is G. Get up and go, 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 like Paw Patrol. And that means movement. Well, the first movement children do is what? They lift their head and then they turn over. This is a child by 1 year old, may not be walking yet, may not be sitting, not supported by pillows, because they should be by 8 months, right? Another thing that happens is because they're going to have also language delays, they're not able to express themselves. Now they're getting to be toddlers, and most toddlers can tell you what they want or need, and it keeps them relaxed. Well, cognitively impaired don't know what to say, how to say it. So they get frustrated. And with that frustration, you're going to see behavior difficulties. And it's not because they're in there screaming and yelling and whatnot. It's they're frustrated. I can't express myself. So again, all the milestones will be delayed. And if you call them, they're not going to be looking at you. It's like they're in their own little worlds as they get older. Now, Down syndrome, yes, cognitive delayed. Poor little Down's children. They have a higher risk of leukemia. They have a higher risk for hypothyroidism, which we're going to be learning that, in the future class. They have a high risk for congenital heart disease. So sometimes we have to remember that Down's children, yes, they're flexible and yes, they're cognitively delayed and they fall. And we think that bruising and whatnot is because they're falling. Remember, what are some of the signs and symptoms of leukemia? It's that bruising, it's that petechiae, it's the pain, etc. So, especially with a Downs child, you're going to make sure you do that CBC. Make sure you look at that white count, see what's going on. Physically, absolutely, you can tell those almond eyes and the tongue comes out. The hypotonia, they could take their feet, put them behind their head. They're so flexible, right? And then there's the creases in the palms of their hands and the soles of their feet. Another thing is their toes. You're going to see, the toes, a wide toe on the side. Instead of all together, it's this wide to the side that holds them up. Another thing very specific to Downs is their noses. They're flat on top, and it's what we call an underdeveloped nasal bone. Well, what happens is mucus can't come out, and it sticks there, and then it drips, and now they're more susceptible to respiratory infections. Okay. Now, cognitively delayed children, especially like Down syndrome, they have extremely high anxiety. So if they have to be away from the parents, that separation anxiety, number one, try to have the same staff working with these children all along to try to decrease it. Try to keep them on their same routines. Those are the two big ones. And if, of course, if the parents can stay, that's the big thing we want. We want them to stay. But we know that they do have other responsibilities and they can't always. Now, autism, similar to cognitive delay, right? So, all of the things I've been saying, you can, put it into autism too. Autism, mostly boys, usually diagnosed about age of 2. And all of these things that you would see of the fine motor, the gross motor, behavioral problems, not wanting to, speak up when their names are called. Now, it's a little bit even more with autism. They don't like to be touched. They don't like to look you into the eyes. They don't like loud noises. They don't like crowds. All of these things can make them irritated. Now, they love to imitate and do these repetitive behaviors. Now, I had the opportunity to do clinicals for Fortis at a PPAC, and there was a little boy there who was autistic Downs, if you can imagine. He was like 4 or 5 years old. And this child, because of the constant way that they did the same thing, the schedule, the routine, he got off the bus because they shipped him in on a bus. He got off, he got his backpack, went inside the door, took his backpack, put it in his little cubby, and sat down and waited for his vital signs. Once he was done, I mean, he might need a little reminder, wait, sit down, we're not done yet. Of course, he's autistic. But when he's done, what does this child do? And I would watch him and I would show the students, whichever students were around. He would take and get a truck or something and put it on top of a stool or a chair. And then he would take a block or a this or that, put it on top of the truck, get something else and put it on top of that. And then he'll go to the point and then he'll take one off, put it back, take one off, put it back, and take them all off. And guess what? He'd do it again. Truck on the bottom, something on top. And he would do this over 10 times in a row. This gives him comfort. It's that repetition. Okay. Biggest thing with autism and children is safety. They're 4 years old, but it doesn't mean little parts in the mouth, aspiration. Remember, safety, 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 cognitively delayed, especially autistic children. Now, verbally, we know at birth, babies cry. Then they start cooing by 2 months. 3 months, now they're gurgling and they're laughing and giggling, right? And now by 8 months, you make a noise, they're going to try to make it to you. If you go, whoa, 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 they're going to try to go, whoa, 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 whoa. I mean, but in their own way, of course, because they do that imitation. By about 10 months ish, they should be saying like mama or dada, hopefully nana for me, right? That's what I want. But one word, okay? Now, by 1 year old, they actually can say a couple different words. They not might say milk, they might say juice, they might say, hungry or whatever, chicken, whatever they're going to say, but little things. Now, what if you have an infant who is in the crib and you walk in and they're not answering you? They're not responding to you until you hit the crib. So, or you're behind them and they don't respond to your name. The first thing we're going to do is, of course, a hearing test to find out if maybe their hearing's decreased. The other way, remember, hearing and speech are connected. If they're not speaking or clearly the way that they should be, hearing should be tested because it could be a problem with hearing. Always rule that out. Now, you do get children, they do get extremely ill and are in the hospital for months at a time, some of them. And one of the things, like with any patient in the ICU, nutrition, your body needs that protein, right? That heals the body up. It needs good fat and it needs sugar in order for the body to function. So that's number one. Many times they'll put tube feedings in small, medium, and large children. It doesn't matter, in order to get the food to them. Now, just like adults, you're going to use a draw sheet to lift and pull them up, especially older children. I mean, little babies you can pick up yourself, but I'm talking something 50, 60 pounds where you might need somebody to help you because you don't want to rump that skin against the sheet, that shear type of injury. We don't want to rip skin off. And they can, just like the elderly. If a child's in long enough, yes, it can happen to them. We're going to turn them, position them, and use all sorts of pressure reduction equipment. I love Beanie Babies, especially on the little infants. I would, if they're intubated, I would take and put it underneath their ET tube so they could look at it. I'd have them hugging one between their legs, holding them so they're not rolling back over. It's used pillows, blankets, nice soft stuff because number one, the parents go, oh, look at my baby, he looks so comfortable. But number two, that little baby seeing this cute little stuffy that mommy had brought in for them. Again, all the bony prominences, all that stuff, we are gonna massage them and keep them from getting reddened. Now, children, we know, how do we examine them? Well, first of all, get the kid comfortable. One way to get a kid comfortable is on mommy's lap. It is actually a program I developed down here in Miami. It's about parents holding children for injections, sutures. We've used it for many different things and found out that children were less stressed before, during, and after. And even the pain was minimal because of the distraction of mommy's lap. So always base your examination on their developmental level. Remember, it's always not just age. Remember, developmental level. When that child, is less than two, sometimes less than three, put in mommy's lap. Again, in the hospital, same routine, encourage the parents to stay there and understand that if the parents have to leave, you're going to see that three stages of separation anxiety. And we can help that by having same staff going in with that child. A little bit of sameness that the child, familiarity for that child. Now, during hospitalization, There are times where children get freaked out for some reason, whether it was a surgery or IV, X-ray, you don't really know. We don't know all things that upset children. And let's say you had a child's upset. How are you going to find out in a non-threatening way what happened? Well, that's dramatic play. It's like they're playing the drama, right? They're making up the drama, showing you, was it that, needle? Was it that blood pressure cuff? Was it the x-ray? Through it, we can get that experience out. Expressive play, again, that's just release of tension when a child's frustrated. And then creative, we like children to put, it's a distraction, right? Putting pictures and whatnot. I mean, the hospital where I worked, pediatrics, had a beautiful playroom for children. And if they weren't something that somebody else could, communicate, their disease to, they could go up to the playroom and play. And I thought it was great, great distraction. Now, children are not going to tell you that they're in pain, right? Because they're afraid of the medicine or the shot, or mommy or daddy saying, no, you're not in pain. But remember, children do have pain. If you have a child post op and you want them to get out of bed, cough, deep breathe, ambulate, all those things, just like you would with an adult, make sure you pre medicate them with pain medicine. Okay. Can you imagine? And children usually won't complain. You'll just see them crying and whimpering because they hurt so bad. But they won't tell you they need pain medicine. So it's something that you have to say, I'm giving you your pain medicine. It's going to help you get up, get out of bed. We're going to ambulate and it's not going to hurt. And you're going to take deep breaths, keep your lungs moving. And that can help. Okay. Always, always, always remember, any procedure we do on a child that's going to hurt, let them know we're going to do everything we can, but it's going to hurt a little bit. Be honest. Children remember these things. Now, one of the things is, how do you give a baby some medicine? Well, if you need some liquid to go in, you squirt it on the side of the mouth. And what I've taught parents to do, because years ago I did it before infection control, you take a deep breath and real quickly in their face, and they swallow it. So I teach parents how to do that. Remember, there are medicines like mycostatin, which is just a for yeast, fungus, thrush in the mouth. What they do is they just take a Q-tip and then dip it in the medicine and then rub it all over the tongue. They don't know how to swish and swallow like an adult, right? So you're going to paint the tongue. IV site. Remember, babies are small. 30 mLs of fluid could be a whole hand blowing up on an infant. So when you see the IV, look for swelling, redness, pain, streaks, blood. What do you do first? Stop it, right? Remember, there are some IV medicines that are going in that might need a treatment before the IV comes out, like your suppressors, like your dopamine. They might need that dilatation registine being put in their IV. So just tell the doctor, and they'll tell you if they want to do anything for that infiltration. And then, of course, you're starting a new IV. Now, infants, we can do every single lab work except blood coagulopathies, your PT, PTT. We can do it on a heel stick. And we can do a complete blood count, all your electrolytes, etc., your big profile, and a CBC for 1.2 mLs of blood. That's hardly anything. So, how do we get it without hurting these infants, bruising the heel, and make them painful? Well, number one, get a hospital approved heel warmer, put it on the heel, and then wait. You're never going to put anything in a microwave or under hot water, and put it on the infant. It must be temperature controlled, which is the hospital approved heel warmer, okay? It dilates the area. I always put that foot below them and I sit down below them when I do these heel sticks. And I'm going to do it on the sides because in the middle is the calcaneus bone. And if that gets hit with a lancet, it causes osteomyelitis. So we don't want to do that. So we hit the side and then we put the leg down and slowly, very gently squeeze it. And because it's down and it's warm, you just take and you scoop up the blood and it works beautifully. You don't want to over squeeze and hurt that little heel. Oxygen for infants, the best is that oxyhood. Look at that infant, up, around, looking happy. You put a nasal cannula on and they are sticking their fingers up. It's air in their nose, and we usually tape it to hold it there. I don't know if you've ever been intubated, but it is not fun. I have been, and I remember it. So it is not easily tolerated. And then CPAP, same thing. It's really not easily tolerated. So oxyhood for your young little infants. So dealing with the stress and hospitalization, we know that one of the most frequent hospitalizations are those chronic kids, right? Your cystic fibrosis, your children with sickle cell disease. Remember, they've had a lot of chance for experiences that could have them scared. So we always remember that as we're working with these children to make sure that we don't scare them again. Also, separation anxiety, biggest stressor is when they're separated from the parents. So allow them to stay in the room, especially like the Down child, the autistic child. There's that difficult temperament. And we know that males are the ones that require a little bit more attention and need parents there more. And they're saying ages 5 months to 6 years. You don't have to know the ages, but cognitive impairment, male, difficult temperament. How do we take care of that? Please, parents, would you please stay? And that's how we take care of the biggest stress. So, biggest stage of separation anxiety is regression. We know that once that the parents come and they leave and then they cry, go crazy, then the second stage, they regress. They start sucking their thumb, or maybe they're potty trained and all of a sudden they're not. And maybe they're now waking up at night. Maybe, they want you in the room a lot, a lot, a lot. So it's one of the things, again, as nurses, maintaining that same staff in there can help. So when we're talking those toddlers and preschoolers, they're the ones that really, really need mommy in there. They're the ones that cannot tolerate change like that. School age children, they're older. We talk to them, we can teach them. They're very teachable, right? Remember, if they're in a hospital, now this is Erickson, right? We're talking about doing things to keep them busy. It could be that they have their schoolwork, or maybe it's playtime and you give them a puzzle. Now, if the child is 7 years old, school age, you wouldn't give them a 1,000-piece puzzle because you're going to frustrate them. Remember, school age children want to do it, complete it, do it well. And if you give them something that's not obtainable, you have just frustrated that child. So always, whatever you're doing to have them accomplish a task, do it something that they're able to. Doesn't have to be easy, but that they can do it. Otitis media, middle ear. Sometimes it can even perforate and it can look like that, stuff coming out of the ear. Remember, children have narrow, short, open eustachian tubes. Mucus goes down the nose, up into the ears. Acetaminophen is great for pain. We use antibiotic drops and oral antibiotics. And then if we're chronic, we're going to get tubes put in there. How do we help decrease the amount of otitis media in children? Number one, always wash hands. That's always, you don't want to spread infection. And remember, middle ear is a staph infection. So it is bacteria. So washing hands or sanitize. Also, getting immunized as ordered by the physician in the normal sequence. And then cigarette smoke is a big one. No cigarette smoke around children. Respiratory dysfunction. Yes. Tracheal bronchitis, right, is also called bronchitis. Remember, bronchitis is an inflammation of the bronchus, and it creates this non-productive, dry, hacking cough that's worse at night. Bronchitis, itis, inflammation, it's swollen, cough, cough when you lay down. And how do we treat this? Well, we're going to give something to suppress the cough. It's the big thing with that. We know that as adults, you go in and you say you have bronchitis, you get a Medrol dose pack and a Z pack. In children, we may or may not just give, some sort of steroids for that. We may or may not give antibiotic. That's always a physician choice. And no fever, usually. Croup is laryngeal tracheal bronchitis. So we have tracheal bronchitis, which is bronchitis. Laryngotracheal bronchitis is croup. Croup is, and bronchitis is upper airway. There's inspiratory issues. Swelling up, air can't get in. Once it's in, it gets out fine. What you hear is this seal-like barking cough. You're going to see this abdominal breathing going on because of this difficulty getting air in. It sort of helps with it, okay? So how do we treat croup? Well, croup is usually virus, okay? There is a YouTube if you want to listen to what it sounds there, but it sounds just like a seal, okay? And it's all upper airway. And what we want to do is, number one, we want to have an airway. That's it. And we want to give steroids and epinephrine. Now, epinephrine is usually given in an aerosol. So the epinephrine goes just right into the mouth, into the airway, and right on to whatever's swollen in there. And it works well. And of course, with the steroids. After we get the immediate treatment, we got our airway open. It's always maintain hydration. They can't breathe, it's going to be IV. But if they're, got better after this epi steroids and they're looking good, this is one that could have oral. One of the things about croup, if they've gotten steroids or epi, in the ER, and then they go home, and now they're starting to have the same symptoms and starts drooling, it's epiglottitis. These are children that we'll say, if you start, we have taken care of the swelling. Sometimes the swelling comes back. If it does, get to the emergency room immediately. It is an absolute medical emergency. One of the immunizations that we can do to help prevent it is the Haemophilus influenza, the Hib. So getting immunizations here can really help. Now, epiglottitis, the symptoms, this is what you're going to see. Child is going to be bent over, almost like that old COPD person, right? Bent over, trying to find a place to breathe. They're going to be drooling. They can't swallow. If they talk, it's so swollen back there, would be like the way that they would talk. Very, very muffled. They're not going to cough. And you're going to hear that if they get air in, that really high pitch type thing. So with that being said, and you're suspecting epiglottitis, you as a nurse put absolutely nothing in their mouth. Only the person who will have, because with epiglottitis, you're going to get someone to get an intubation and a tracheostomy tray at the bedside now. So that when the physician comes in to check this child, if they look inside the mouth, it swells more, they have the ability to quick get an airway. Epiglottitis, drooling, we need an airway. Cystic fibrosis. Cystic fibrosis is a multi-system problem. It has to do with electrolytes. It has to do with mucus in the lungs. It also has to do with mucus in the small intestines and the inability to absorb fat into the body. So let's go over this. If this is very similar to to sickle cell anemia, a 1 in 4 chance that 25% will have the disease when both parents have the trait. Okay, same thing. Now, sometimes we don't know this child has the possibility of cystic fibrosis. I mean, today they're doing testing, yes, but does that mean everybody's getting tested? So one of the first symptoms you will see is that meconium ileus, which means no stool at birth for the first day or two. That is telling you one of the things it could be is cystic fibrosis. So, how do we diagnose it? It will be with a fluoride sweat test. So, what happens with cystic fibrosis is you lose sodium like crazy, and the pancreas doesn't have enough enzymes to digest fat. Now, the pancreas is already under stress. So, one of the things that can occur is that they end up as young adults with diabetes mellitus type 2. Remember, like I said, adolescents should be involved in their own care. Remember, they're growing up, they're moving out of the house. You need to include them in the teaching. So, what are things that you see because of the respiratory, all the mucus, and the pancreas? What do you see? Well, one of the things I said, the pancreas is not giving enough enzyme to digest fat. So if you eat fat, it's still there, but it makes the stool large, bulky, extremely oily, and the worst stool smell that you'll ever smell. It's also called steatorrhea. Because you're losing fat, you're also losing fat vitamins, A, D, E, K. Got to watch it. Do you remember in nutrition when they talked about how many calories per gram of protein, fat, and carbohydrates? Fats are 9 grams, 9 calories per gram. The other two are 4. So where's a bulk of the calories coming from? Fat. And the fat can't be absorbed. So these children are going to be at risk for nutrition deficiency and weight loss. Now, there's mucus in the lungs. They are having aggressive chest physiotherapy. So your lung sounds will be all over the place. It's going to be uh, dry, non-productive to wheezy to rhonchi to difficulty breathing, et cetera, et cetera. And because they are immunosuppressed, these children are going to have a lot of respiratory problems. And they're in and out of the hospital. They even get antibiotics in their aerosols to try to help. So I said, these children have nutrition issues. They're losing an incredible amount of sodium in their skin. If you were to lick, and I'm not telling you to, if you were to lick one of these children's skin, you would taste salt, like real salt. Like it's very distinguishable. You would know it. So they're losing electrolytes, their sodium, right? They're also, with their food, they're not getting any of their fat. So what sort of nutrition would be appropriate? Well, we're going to try to decrease the fat in their diet, right? But high calorie, high protein, and give them a salt shaker. They need it. They're going to get vitamins, the fat vitamins as they need it. And before they eat, they're going to get a bronchodilator first. And then they give chest CPT, get rid of all the mucus. Then they're going to get their pill for eating, and then they can eat. They say, eat, they do the therapy before you eat. Can you imagine doing aerosols and chest CPT and putting these vests on which vibrate after you eat? These children will vomit. So please do it before they eat. You don't want to do that. Now, this is one of your NCLEX questions. I know it's out there. I don't know if you've had it yet, but you're going to get it. Pancreatase enzymes. This is what's missing in the children, so they can't digest any fat at all. So it does come in capsules in those little tiny little beads. They're enteric coated. You can't chew them, or you can't open them. You need to leave them just the way that they are. No crush, no chew. Then there's also stuff that's just powder, and you just put it on the food, or the little balls, a little bit of food, and take it so that you get most of it before you eat, okay? And if you're doing the powder, always rinse your mouth out. It does hurt the enamel on your teeth. One of the things I think, just globally in every type of condition, we forget children grow. There are some years they gain 2 pounds, but there could be a year they gain 10. Make sure that the enzymes dose increases according to how they're growing. Now, there is a need or a want, desire to have children when you have cystic fibrosis. Now, women can get pregnant, but they're extremely high risk. The problem is males with cystic fibrosis, they also have clogged vas deferens ducts, so they can't get the sperm to the wife, the girlfriend, the woman, to have a baby. But I don't know why, after bilateral lung transplant, they can father a child. And many men will do that. Crazy, huh? I don't know why the vas deferens all of a sudden can. I'm not really sure about that. Some chemical, something, I'm sure. Now, what's the one thing kids do all the time? Surgery. Oh, it's going to be TNA and tubes. I think that's like on the docket. In fact, one of my students can't come today because her son was having a TNA today. So it is one of those things. Now, when we're talking about tonsils, adenoids, tubes, post-op care, most of these children are not to stay in the hospital. They go home because they can be calmer, more comfortable, their own foods, their own environment. It's better. Now, when they get out of surgery, let me explain what they do in surgery so you can explain why I say the things. Those two big balls between that little long dangly thing are your tonsils. They take a scalpel and cut them off. Foop, foop. And then they take and cauterize the bleeding area. So now you got big scabs there. Adenoids are a little bit lower. So the whole back of your throat is a big scab. So avoid irritating and highly seasoned foods because it will burn. Okay. You still need liquids. I mean, you still need them, but remember, nothing red. Jellos, ice pops, all those things. But remember, nothing red, because you want to make sure that there's no bleeding going on.
Now, I saw this question and I can't remember exactly what I saw it on, but it said something about applying an ice pack to the neck. Is
An
that
ice
helpful?
collar. Absolutely. It's
Okay.
called an ice collar. Now, young kids hate it. They're not, oh, it's cold, get it out of here.
Mhm.
Older children and your adolescent, it's cold. It goes right there and it works. I had TNA done at age 21. I know what it felt like. And that ice collar was amazing. But young kids won't. We know popsicles and ice chips is all cold. It's really good. These children need to be calm, cool, and collective up to almost 2 weeks post-operatively because those scabs can come off. Now, it's normal to have a sore throat. It's normal to have pain post-operatively, but, going on more than 2 weeks or you're smelling and fevers, you need to get to the doctor for that one. Another thing immediately postoperatively that we need to teach parents, and of course, if we're working in that recovery area, to know that if you see a post tonsillectomy, number one, they should be on their side so that blood can come out, and keep their airway open. Number two, if you start seeing them waking up and swallowing, they're bleeding. So it's something that needs to be told to the doctor. I'm going to tell you a little story so you understand. I had a little girl who had just come from the ENT doctor, and it was 7 days post-operatively. On the way home in the car, she vomited, and it was a big clot of blood. So they ran her to the emergency room. I'm in triage, and she vomits all over the floor, more clots. I get one of those big pink buckets and I hold it there. I do their vitals, see what's going on, and this girl's pale, vomits more. I had to pick her up, bring her into trauma room, get the doctor, get IVs, and this little 7-year-old girl, I had to give a whole liter of fluid. She had to go back to the OR and get the area recauterized. It was bleeding. So it is real and it does happen. And she was in hemovolemic shock. I mean, she really, heart rate was 160, blood pressure was 70 over something. Yeah. But anyway, she did fine. Now, the other thing you don't think about is chewing gum. Remember your station tubes swelling back there, going up in an airplane, your ears pop, right? Chewing gum, same concept, keeping those ears popping because it's pain and pressure. Asthma, chronic non-productive cough, and it's expiratory wheezing. So croup, epiglottitis, inspiratory. Asthma, the air gets in and there's swelling and expiratory wheezing trying to get that air out. And this is afebrile. It has to do with, structural, doesn't have to do with infection. Now, we call it a bronchial hyperresponsiveness. That means something that's causing the lungs to say, I didn't like that. Whether it's foods, whether it's grass, leaves, flowers, dogs, cats, it's all different things it could be. And they'll tell you, get rid of them. And, their favorite cat, you're allergic. It's a hard thing to do. But with asthma, it would have to be done. Now, symptoms frequent cough, they lose their breath easily, that expiratory wheezing. Now, what if all of a sudden you're not hearing any wheezing going on at all? There's no air moving at all. My husband went into status asthmaticus, was in the ICU for 12 days. And his breath sounds, to tell you what it sounds like, is I didn't hear any air going in. And at the end of a breath, I heard and that was all I heard. So it does. The whole lungs do climb down, and that is something that, of course, needs emergency treatment. Now, one of the things, and it was one of your discussion questions, all about that peak flow meter. We encourage asthma patients, especially those brittle ones, to be checking their peak flow every day. And if they see the numbers going down, give an aerosol, open the lungs, be preventative, right? Albuterol is your rescue. The spacers are great for young kids. and even adults who can't push and inhale and walk at the same time, right? It's a great thing. I've seen it used in all different ages. Remember, any person with respiratory distress needs the head of the bed elevated. All right, pulls the diaphragm down, opens up the lungs the best that they can. We give corticosteroids for that acute stage, decreasing that inflammation. And then we use that medicine um, in adults, as Advair, Brio, Symbicort. In children, it's called Pulmicort, and it has that little bit of steroid in it, and it's given morning and night for preventing your attacks. So it's the preventive, keeping your lungs from being so hyper responsive with that little bit of steroid, and then the rescue we use when we can't breathe. One of the greatest things for exercise for a child with asthma is swimming. There's no antigens there, right? There's no allergens, and then you have to hold your breath to go underneath, and it's actually good for your lungs. Now, RSV. For me and you, it's a common cold. For an infant, they can barely suck, swallow, and breathe with a little bit of secretions in the nose, and now they're in respiratory distress. One of our concerns with that is that child who is already immunosuppressed, like a premature child, a cardiac child. So we want to prevent it. It is very contagious. And that's why if we're in the hospital and we're admitting young infant with RSV, finding out about their immunization status and whatnot, very important because it is so contagious. Now, what do we do? What's the treatment? Well, the immunization is only the first year, and it's from early winter to early spring, once a month. And the biologic name is palvizumab. And then the brand name is Synagis. You need to know palvizumab, okay? And that is given once a month to prevent RSV. Now, many times this respiratory distress and you can't breathe, and the way is to have nice, moist air going into that child. And there is these cool tents we can use. Sometimes the children, especially like toddlers, they're scared, they're inside this plastic. So another good opportunity to still get all that mist is have them sit in their lap, the parent's lap, and then put the hose with all of that moisture going in their face. They're still getting that mist that they need. Now, pneumonia, we can have it because of feeding. And don't forget, pneumonia is not just all bacterial, it's also viral. So if it's aspiration, we're going to be teaching that parent more about that frequent burping, don't overfeed, having them sitting up. And then, of course, the powders, the chemicals, and smoke shouldn't be around them. Now, if it's viral, it's like having a viral upper respiratory infection. All we do is treat the symptoms, supportive, acetaminophen, ibuprofen, fluids, rest. That's it. Okay. And then, of course, with bacterial, all of the other stuff, but they usually have a good fever going on. So we will be given, and it's usually staph. So it's augmentin, always number one drug of choice. Mononucleosis. This is called the kissing disease. No big deal. It is a virus, Epstein-Barr virus, and it's hard to diagnose. This is the child that goes into the doctor with complaining of fever, fatigue, rash, swollen glands, don't feel good. And they do a strep test, they do culture, everything's negative, so they send them home. It's a virus. Come back 3 days later, still don't feel any better at all. They say, well, I didn't see anything on anything, but let's start an antibiotic. 3, 4 days later, now they've gone to the ER. And they come in and they say, all of those symptoms still the same. and this is the antibiotic, and I still feel horrible, and we will draw labs. Well, number one, we want a CBC. We want to see the white count. Is it elevated? Then it's bacterial. If it's normal, it's then a virus. Also, we're going to do something called a mono spot test. Mono spot test with these symptoms, and it comes back positive. This child now has mononucleosis. You have a diagnosis. The biggest concern with mononucleosis is that their glands, their lymph nodes swell, especially liver and spleen can swell. It's like a big balloon that can pop. Okay. Biggest concern, no sports. Protect that abdomen. I had a 9-year-old boy, did all those things, symptoms, came in just like I said with his father. We did the mono spot. It was positive. I did big teaching about protecting that abdomen. And did he have any brothers that they couldn't be wrestling and fighting? And the doctor gave a great, discharge. And I gave written instructions. 1 week later, this 9-year-old boy was out in the Everglades on an all-terrain vehicle, fell off onto his abdomen, and came in on rescue helicopter, and he was dead on arrival. He burst his spleen, mononucleosis, kissing disease. So now you hear it. Protect the abdomen. Okay, congenital heart defects. Don't worry, the exam is not overly crazy on congenital hearts. And I know that's some of your big concerns. Now, you need to know signs of heart failure, okay? Which is rapid heartbeat, tachycardia, rapid breathing, tachypnea, swelling, tired, restless, exercise intolerance, diaphoretic. Now, they're not eating much, right? Because they can't breathe. But all of a sudden, you're going to see that scale, that daily weight. All of a sudden, you're going to see a gain in weight because now they're gaining, they're not getting rid of any of their fluid. It's going right into their heart, right into their lungs. Okay. You might see a blue tinge if it's a cyanotic heart disease. You may not if it's just a acyanotic. With that congenital heart defect, as I said, they're fatigued, they have rapid breathing, they're hypoxic. Now, how are we going to treat these children? They still need to eat, they still need nursing care, right? So, we're going to do cluster care. We're going to give small, frequent feedings. And then because they tire out quickly and don't eat as much, we're going to increase the calories in the formula. Now, normally the formula is 20 calories per ounce. When we talk about a congenital heart, we can do up to 27 calories per ounce, and we can even add more to that. So there's ways to get the nutrition in there that we need. Also, remember, limit your feedings to 30 minutes. After that, you're just tiring the child out. Let the child rest. You might hear murmurs, and then remember those pulses. If you don't have pulses, sometimes it even starts in the femoral artery, brachial, or salus pediis feet. You don't have pulses, that's coarctation of the aorta. Remember, no pulses down, and up above, they are 3+ bounding because all the blood goes up, it can't go down. There's a kink in the hose. This is all of your type of congenital heart defects. Atrial and ventricular septals, that is a hole between the midsection. That means blood that's come back from the lungs can go back over to the other side. So that's why it's an increased pulmonary blood flow. I've just talked about coarctation of the aorta. And remember that the most tested cyanotic heart disease is tetralogy of Fallot. This is the knee chest if it occurs, right? It's all of a sudden they go from stats of 100 and I've seen it on me. They did it to me to a saturation of 10 in 2 minutes. It was quick. And then you just knee chest, and it will change pressure in the abdomen and the chest, and most of the times we'll pop it off. And then the other one is your transposition. You just have the lungs and the aorta, they're on the wrong side. So you don't have any mixing of blood. The trilogy of Fallot has 4 stages, conditions with it. It is all right-sided. If you can remember what are the structures on the right side, know that most of your TET children will be placed on digoxin. They're also, during a spell, will get some morphine. But remember with tetralogy, especially older children, you're not going to be successful if you can't calm them down first. So always number one, have them calm. And if it means being on mommy's lap and you doing knee chest over there, well, that's what you're going to do because that's the way to do it the best. Okay. Your patent ductus arteriosus. I call it my oxygen giver. It's giving me oxygen from my lungs, pulmonary artery, and it's giving it to my body, which is the aorta. Now, mommy normally is making this hormone when she's pregnant. Once the baby's delivered, the prostaglandin is gone. And usually it'll close up within 21 days, they say. You don't have to know that number. Now, at birth, you're going to hear a machine-like murmur. And then if it's going to close, you're going to hear it close pretty quickly. Now, if you need to keep that open, you just need to give the prostaglandins. Mommy's not there anymore, so you need to give synthetic prostaglandins in a continuous, slow infusion. What does prostaglandins do? It's an oxygen giver, and it also helps with cardiac output. Very important. Prostaglandins. It increases oxygen. It's an oxygen giver, and it helps with cardiac output, and it prevents any problem with that central nervous system because of lack of oxygen, okay? Indomethacin is a drug that we give to close a patent ductus arteriosus that doesn't close by itself. Most of them I've actually see are very young, premature infants, and those they don't close. So they'll give the 3 doses. And if that doesn't work, they'll do surgery. They actually just put a staple. Atresia is no opening, like tricuspid atresia, no opening between right atrium, right ventricle. Stenosis is a narrowing. That means it's not open enough. Removing chest tubes. We're talking removing chest tubes. We're talking about doing something post-operatively to a child that's had some big surgery, abdominal surgery, open heart surgery. Whenever you want to do anything, remember, number one, medicate for pain because it's going to hurt. And then you need to be honest with that for that child, okay? Always be on their developmental level. And with giving pain medicine, you're going to do vital signs before and after, okay? Transplant, biggest risk is rejection. And many times, some of these bad cyanotic heart defects end up with transplants. Digoxin, like I said, we're going to give that with tetralogy of Fallot. It's one of the biggest things we give. It slows and strengthens the force of contraction. Now, you need to know all of those little things with administering it. What were you taught in pharmacology? Well, you need to do a heartbeat for 1 minute. And they say less than 70 in a child, 90 in an infant, or if something else is said by your the physician, it should be 1 hour before or 2 hours after a meal. That means empty stomach. Same time every day. Remember, if we are in the hospital, you are checking potassium levels. If it's too low, you're not going to give it. and you're going to check the digoxin level to be sure. When we send them home, the biggest thing is telling them one of the signs and symptoms that most parents can figure out. If a baby vomits, we know that all of a sudden it vomit and they've not vomited. Maybe a little spit up normal, but vomiting, that could be dig toxicity. And it's better to call the doctor, be safe, than it is just to give it and say, oh, it's just a vomit. Okay. Post cardiac calf. Remember, they put in a tube into the right artery, femoral artery, right femoral vein. It's a big, big hole there. Biggest thing is to check that dressing before. First thing, making sure there's no bleeding going on. If you see it wet, you see blood, you put your fingers, 2 fingers right above, hold pressure, and call for help. If it's okay, no bleeding, you'll check for pulses. Now, probably it's going to be slightly decreased because they put big tubes in there and a little bit of inflammation's occurred there. Big thing post cardiac calf. Keep the legs straight and bed rest 24 hours. You're going to do vital signs. You're going to be giving hydration orally or through the IV. And one of the things that we monitor, especially with infants, is their blood glucose. Because especially when they first come back from the cardiac cath, did they get any IV fluid with sugar? And infants need sugar more frequently than does older children. Rheumatic fever is due to a strep throat that wasn't completely treated. You'll see fever, joint pain, rash. One of the things that if we let it go so far as and not get treatment, it could affect the mitral valve, heart valve damage. Once it is damaged, it's not going to be fixed by giving long-term antibiotics. Everything else, even the chorea, that central nervous system, even that's all going to go away. All right. But not the valve. So it's long term antibiotic treatment. ITP, P for platelets. Not enough platelets. What do you see? You're going to see little petechiae. You're going to see ecchymotic areas. I mean, this is low platelet counts, usually below 20,000. It's usually you've seen an upper respiratory previous in the last month or something. When we find that low platelet count, they're going to be admitted. They're going to be getting an IV with IV immunoglobulins and anti-D. Now, nursing care. These children bleed easy. Platelets are just like not having a factor VIII. I mean, it's one of the bleeding cascade, the thing that you need to bleed, to stop the bleeding. So, no venipunctures. You're going to be teaching, especially children that are older and understand enough. You know, adolescents that can't shave, right? Boys or girls, or toothbrushes. Are they soft enough? Monitoring, is there blood in the stool or urine or nosebleeds? Teaching, teaching, teaching. Now, the other thing is we'll draw CBCs every day usually, but we'll take it out of the IV. So we're not sticking them as a venipuncture and monitor those blood counts. And this says sometimes corticosteroids, but I've always seen just take gifts, corticosteroids, it just helps. Types of anemia, iron deficient, not enough iron in the body. How do we treat it? Diet. And if we don't have diet, we're going to give some medication, some iron. Know that there is an IM one called iron dextran, and it's deep Z trap because it burns and it stains. Know how to give liquid iron to a young child. Remember, through a straw, should be on an empty stomach, no milk. And if you're drinking, orange juice is really the good choice. Iron must be broken down in the stomach with the stomach acid for it to use. And if you do the orange juice with it, it breaks it down even more. So it's what you do need for that. And remember, their stool is going to turn black. Please tell the parents. It is scary. Now, megaplastic anemia, B12 deficiency, you would see this beefy red tongue. And so you'd look at the tongue if you were wondering. There's something called a hemolytic anemia, and there are things that make cells burst. There one that's we was quickly gone over in farm GPG6 something thing where they can't have sugar, and you got to be careful with like even ibuprofen with sugar. They have to have one without sugar in it. But it's a cells burst, hemolytic. Sickle cell anemia. We know those are sickle, we'll go more. Cooley's anemia, thalassemia. This is that fourth stage, but that's what we test on. Remember, you have oxygen and iron being spewed into the body. Cells die so quickly. So the treatment is blood transfusions and some sort of iron chelation therapy because it's that serious, that much iron is in there. Remember, aplastic anemia is white blood cells, red blood cells, platelets. So it's attacking your immune system, white blood cells, your hemoglobin, and also platelets bleeding. That's we treat that like leukemia. Sickle cell is when cells get stuck in the blood vessels. So you have a sickle cell going through the body, it gets to a bifurcation, and all of a sudden one gets stuck and it covers up that bifurcation. And then the next cell comes along and oh, stuck. So now you have this backup of all these red blood cells. No blood's going lower, and all of them, they're just stretching, and now it's creating pain, it's redness, swelling, and these poor children are hurting. So, what caused that red blood cell to get stuck? Well, the blood vessel wasn't large enough, dilated enough for the cell to get through. And one of the biggest causes of sickle cell crisis is dehydration because of the cells, the shape. If they keep hydrated all the time, blood flows and they're not going to get stuck. So, number one teaching, keep hydrated. If they're in sports, make sure they're always drinking. High protein, high calorie diet. Okay, they're immunosuppressed here. If they're going in an airplane, remember they're going up in pressurized cabin. Drink extra fluids to try to keep those vessels big, right? Keep them exercising, of course, pain medicine, and they go home and they give them, a small codeine pill. And again, take it before it's too bad. And sickle cell children must rest. So they can play sports, but please have those frequent rest periods. Now, HIV, we're not concerned with the mom who had HIV, but the baby that she passed HIV onto. So at birth, we have a newborn infant, and now they have HIV. They have a compromised immune system. The biggest thing that we want to do is to boost their immune system with antivirals, okay? One of the biggest things, besides, of course, pneumocystic pneumonia is the big thing that they get in respiratory compromise and they collapse. But commonly, that candida esophagitis, which means their tongue is full of the yeast, right? Again, using that nice statin and swabbing it with a cotton swab is what you would do because I can't spit and swallow. So, as I said, HIV, improve that immune system, give good nutrition, right? Don't have good nutrition, the body's not going to work for you. And then, of course, this is symptomatic treatment. And then, of course, try to prevent, this child from getting diseases, good hand washing. Osteosarcoma, it's a cancer of the femur bone. The femur bone has to be completely removed. What you would see is a child starting with complaining of pain in the upper leg, whether it's close to the knee, close to the hip, anywhere. And it progressively is feeling worse and worse, and especially now in the morning, they're even really feeling it. So they do an x-ray and they find this fuzz. So the goal is they've got to take the whole bone out. Many of these times, these are young adolescents. So it's that body image area where you want to have them have the ability to be ambulatory. So what they do is they take the whole leg off the body. They take the lower leg, the calf, turn around and put it up into the hip. So now you've got the lower leg on you backwards, so we can put a prosthesis so this child will be able to be ambulatory. Now, if you can't salvage, of course, amputation is what they have to do. Leukemia. Leukemia is the white blood cells where they're not working right. So, of course, they have no immune system. As I said, Down children are the higher risk for getting it. How do we treat it? Well, first 4 to 6 weeks is intense chemotherapy. One, two, three types of chemotherapy agents. It all depends on a physician. The goal again is to achieve remission. And you're saying remission? Yes, we wipe out all the cells, but there might be some sneaky ones that are hidden. So we go on and do more to be sure to be safe. Again, giving antiemetics before we give these treatments is good for these children. We do bone marrow aspirations on these children. Remember, it hurts. As much as all of that numbing, you literally hear a as they screw that thing down into the iliac crest. So, it does. Be honest. Another thing, you need to know bone marrow transplants. Where does it come from? Well, some parents have the money to be able to save their cord blood on their newborns. Many don't because it's expensive. It's like, do I buy groceries or we save cord blood? You know? But if perchance that we had it, if I got my own bone marrow, it's autologous or automatically mine is the best. Okay. The other one is all the others. It does not have to be matched with blood types. They do say that siblings are the next best after themselves. And infection is the biggest complication of stem cell transplants. Child with cancer neutrophil counts. Well, this is mentioned because when we're given chemotherapy, we're knocking out their immune system. And we've got to be prepared for that so that we wear our masks, our gloves, and protect the child. But what's the other thing with neutrophils and a patient who maybe is just, in the hospital with sepsis or had surgery or something? And you check the morning labs and you see one of your patients has a neutrophil count of 400 and you're checking the vital signs this morning and they have a temperature of 100.6. Well, this is the child, the patient that you're going to see first because there is no immune system and they're going to go into septic shock very quickly. So, neutrophil counts, white blood cells, you're concerned about infections, especially if those counts are low. It does not have to be in cancer or leukemia. No, it could be just a patient who comes in who's had abdominal surgery, a ruptured bowel. It doesn't matter. It's looking at that neutrophils. Now, one of the questions on the exam is about either Hodgkin's or non-Hodgkin's lymphoma. And how do we figure out which one's which? Because their names are almost the same. So, Hodgkin's is a Hodge. It's a lodge. It's enlarged. You can see them, painless lymph nodes supraclavicular, above the shoulders. You can feel them, you can touch them, they're painless. It grows and it pushes against the esophagus and the trachea. So there could be that cough. Non-Hodgkin's lymphoma is not a house, it's not a lodge, it's diffuse. It's everywhere below supraclavicular, but you can't feel it or touch it. You have to find it. So Hodgkin's is a house. I could touch it and see it. It's enlarged. Usually those big ones in the neck is what you see. Brain tumors. It's a little occupying something in the brain, and it's going to be getting bigger. And as it gets bigger, you are going to have a progression of symptoms. Headaches getting worse, vomiting not related to eating. And it could be a change in behavior. It also could be like your balance is going off too. One of the things they do for brain tumors is they'll do radiation to shrink it. They put those little purple little marks, never ever wash them off. That's exactly where that radar gun's going to go next time. Wilms tumor, a kidney tumor, nephroblastoma, or a Wilms tumor. It is this extremely fragile tumor on the kidney. The biggest concern of nursing preoperatively is do not palpate the abdomen, because if you do, little bits and pieces could fall out and now it's metastasized. They do not even do a biopsy preoperatively because that will open it up into the abdominal cavity. Okay. Postoperatively, you need to be concerned about, if they're urinating and if they're moving their bowel. Now, we did have a CPR question last time, so we'll mention it again. Just know that the one thing with CPR and children, if you're alone, you start chest compressions and you do 30 to 2. And then when somebody comes, you do 15 to 2. That was about the last question. The other thing is, remember, you have parents. Sometimes, like if they're in the hospital setting, remember, the parents need somebody there for them too. There's the whole algorithm. I have put all your cahoots here, and I know you're going to be good. I've given a really good review. And if you listen, you're going to do fine.